Summerfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information on all things O&G. Today, we're talking about Breech, those cheeky little babies that just won't turn head down. First of all, how common is breech presentation?
Breech presentation occurs in up to 25% of pregnancies at 28 weeks, but most of these babies will flip to a cephalic presentation by term. We tend not to worry so much about a breech baby earlier in the pregnancy because there's relatively more amniotic fluid, which allows the baby to be highly mobile. I'm sure you've all popped a scanner on those preterm babies and seen them bouncing all over the place. Only 3 to 4% of babies remain breech after 37 weeks gestation.
So it's probably important that we explain what a breech presentation actually is. Breech presentation describes the fetus whose presenting part is the buttocks or the feet. There are 3 types of breech presentation: footling breech, complete breech, and frank breech. Footling breech is where the baby is presenting with one or both feet first. Complete breech is where the baby is sitting almost cross-legged with flexed hips and flexed knees. And frank breech is where the baby is presenting bottom first with the hips flexed but the knees extended. It can sometimes be difficult to remember the difference between complete and frank breech. I like to remember it by thinking of babies in complete breech as those who have reached complete enlightenment and picture them with their legs crossed like a little Buddha. Frank is a bit more of an exhibitionist, and so frank breech babies tend to have both of their legs up in the air.
Frank breech is also the most common type of breech, accounting for about 50 to 70% of breech babies at term. This is followed by footling breech, which accounts for 10 to 40%, and then complete breech, which is the least common at 5 to 10%. Again, you can remember this by thinking that exhibitionists like Frank are much more common than Buddhas who achieve complete enlightenment. So, how do these babies get into this position in the first place?
Babies might present in the breech position for a number of reasons. It could be that there is a uterine pathology preventing the baby from presenting cephalic, for example, a Müllerian anomaly like a septum or bicornuate uterus or a lower segment fibroid. Babies might also present in the breech position because of fetal anomalies, for example, hydrocephaly, a sacrococcygeal teratoma, or a neck mass. In general, breech babies have a higher frequency of major congenital anomalies, about 6.3% compared to the standard population risk of 2.4%. It could also be because of a placental anomaly, like a placenta previa, or an amniotic band or shelf. Maternal, fetal, or placental anomalies can occur in up to 15% of cases where the baby is breech. This is why it's so important to perform an ultrasound to check and see if there's any reasons why the baby might be breech in the first place. But by far, the most common reason is just because, idiopathic if you prefer the technical terminology.
There are multiple risk factors associated with an increased chance of breech presentation. We've already mentioned a few of the obvious ones, like prematurity, uterine abnormality, fetal anomalies, and placenta previa, but there are quite a few more. These include multiple gestation, oligo or polyhydramnios, fetal neurological impairment, maternal hypothyroidism, contracted maternal pelvis, female sex, maternal anticonvulsant therapy, short umbilical cord, older maternal age, and nulliparity. There's also some suggestion that there might be some heritable component to fetal presentation that can come from either parent. Parents who are themselves delivered at term from breech presentation are twice as likely to have a child in breech presentation compared with parents who are born cephalic.
How interesting.
Good fact. There's also a risk of recurrence that depends on how many pregnancies you've had with breech babies. If you've had one breech baby, you've got a 10% chance of your next baby also being breech. After 2 breech babies, there's a 25% chance of the next baby being breech. And after 3 breech babies in a row, there's a recurrence risk of 40%. Recurrence is usually due to recurrent fetal, maternal, or placental abnormalities, but as Mel said, it might just also be because of genetics. So why does it matter if babies are in breech position?
Breech presentation is associated with increased mortality and morbidity, largely due to preterm gestation, congenital malformations, and birth, asphyxia, and trauma. Breech babies are more likely to have complications than cephalic babies. In particular, breech babies are at an increased risk of cord prolapse. The highest risk of cord prolapse is with a footling breech at 15%, then complete breech 5%, and 0.5% with frank breech. Breech babies are also at risk of head entrapment with delivery, both with vaginal birth and caesarean section, although it's much a bigger deal at vaginal birth. And they are also at risk of spinal cord injury with neck hyperextension. So how do we know if the baby is breech?
There are several clinical findings that might suggest that a baby is in a breech presentation. Symptomatically, the mum might tell you how she thinks baby is laying, or she may have felt a big roll as baby moved into the breech position. Often mums will know exactly where the baby's head is, especially if it's sitting somewhere uncomfortable like right beneath her ribs. She may also feel fetal movements like kicking in her lower pelvis or over her bladder, which is always fun. Next, we have our clinical examination. As you perform Paulick's grip or feel for presentation and engagement, the astute clinician may notice a slight difference in firmness between a head and a breech. You would then palpate for the fetal head, which is often found in the upper abdomen and a bit more mobile than a breech. Finding the fetal heart in the upper abdomen above the umbilicus instead of the lower abdomen can also be a telltale sign that you have a breech baby. The next opportunity to detect a breech clinically is on vaginal examination. You do that VE expecting to feel a firm fetal head, but no, it's a soft, squishy buttock instead. Or you might even feel an anal orifice or even feet. Once the membranes are ruptured, you might also see thick, formed meconium, which points you to the suggestion that there is a breech.
One of my favourite midwife team leaders is always a bit suspicious every time there's a baby with mech-like or in labour. She's always like, is it breech?
And rightly so.
Yes. Now, how good do you think we are at detecting breech on clinical examination?
Well, I guess a butt feels different to a head, so we must be pretty good, like 85-90%, right?
Wrong. We're actually terrible. Abdominal palpation has a 70% sensitivity for detecting breech, which means we're missing about 30% of breech presentations at term. Now, we all know someone who's missed a breech presentation. Hey, it might even be you who's missed a breech. But that doesn't mean our clinical skills are terrible. Heads and bums can feel very similar, but it's important to know the limitations of clinical examination. By far, the most accurate way to detect a breech presentation is by ultrasound. For this reason, many departments will routinely do a bedside ultrasound at 36 weeks to identify the fetal presentation. This allows detection of breech antenatally and more time and opportunity to discuss management options with the woman rather than if she presents in labour with an undetected breech.
Okay, so let's summarise some of our breech statistics. The incidence of breech is 25% at 28 weeks and 3 to 4% at term. There are 3 types of breech presentation: footling breech, complete breech with both hips and knees flexed, and frank breech with hips flexed and knees extended. Frank breech is the most common and complete breech is the least. Less Buddhas, more exhibitionists. Babies might be breech because of fetal anomalies, placental anomalies, or uterine anomalies, but the most common reason is chance. Breech is more common in nulliparous women and in preterm deliveries. And if you've had a breech baby before, you've got a 10% chance of having a breech baby again. Complications of breech include cord prolapse, head entrapment, and spinal cord injury with neck hyperextension. And with abdopalp alone, we can miss up to 30% of term breech babies. Okay, so now we've covered the background information about breech. Let's get into the next part of the episode. What do we do if we find a breech baby at term?
All right, so say you're seeing someone in an antenatal clinic, you do a palp, you think they're breech, do a little bedside, they are breech. Next thing we want to do is arrange a formal ultrasound. A formal ultrasound can provide lots of useful information in determining management. Firstly, it may help us determine why the baby is breech. Are there any uterine, fetal, or placental anomalies that might have been missed on the morphology ultrasound? Most of the time, the scan will be normal. The next role of the ultrasound is to determine whether there are any contraindications to either ECV or vaginal breech delivery. Specifically, we want to know the fetal weight, whether the neck is hyperextended, the location of the placenta, and presence of oligo or polyhydramnios.
Our options at this point include elective caesarean section for breech presentation, vaginal breech delivery, and external cephalic version. So let's get into ECV. What is an ECV?
ECV stands for external cephalic version, which basically refers to changing baby's position to cephalic through external manipulation of the fetus through the maternal abdomen. The idea is to achieve a cephalic presentation in order to allow a safer vaginal delivery and to reduce the frequency of caesarean sections.
We would typically offer an ECV from 36 weeks for nulliparous women and from 37 weeks in Maltese. Nulliparous women have a low chance of spontaneous version after 36 weeks compared to multiparous women in whom spontaneous version is more likely. So we do give Maltese a little bit more time for the baby to turn on their own. The reason we don't offer ECV before 36 weeks is because there's a reasonable chance that these babies may revert to cephalic on their own without any intervention. There's also a small possibility of requiring delivery from complications of the ECV, so we don't want to risk that at a too early gestation. One study demonstrated no clear benefit of ECV less than 36 weeks. It does not reduce the rates of non-cephalic presentation at birth. There's no significant effect on Caesar rates, but there was a significant increased risk in preterm birth. Now, there's no upper limit to which the gestation you can perform an ECV, although complications may be more common at a later gestation. It's still worth a try. Now, what about doing an ECV in labour? Is that something we can do?
Intrapartum ECV is possible, but only if the membranes are intact and there are no contraindications. I've certainly seen this be performed before with a patient at 4 centimetres dilatation and membranes intact with great success. It does require uterine relaxation and avoiding manipulation during a contraction, though. Okay, so who should we not offer an ECV to? What are the contraindications?
Now, there is definitely a mnemonic for this. Absolute contraindications to ECV can be remembered by the March mnemonic, which is the birth month of me, so you can't forget that either. Multiple pregnancy, except for the second twin, abnormal CTG, ruptured membranes, contraindications to vaginal birth, hemorrhage, APH in the last 7 days. Relative contraindications include SGA with abnormal Dopplers, preeclampsia, oligohydramnios, major fetal anomalies, and major uterine anomaly.
Now, it's important to note that there is no clear consensus on eligibility for or contraindications to ECV. There's no evidence to say that fetal macrosomia or the presence of a nuchal cord should be contraindications to ECV, and there's really only evidence for abruption, preeclampsia, and abnormal Dopplers. The rest of the contraindications are based on consensus because of a low likelihood of success or an increased risk of fetal harm from the procedure. ECV after one previous Caesar also appears to be safe. However, there's insufficient data to determine the risk of uterine rupture. Okay, so once we've excluded contraindications to ECV, it's time to talk about ECV itself. How do we actually do one?
So firstly, we want to make sure we're in the right setting, somewhere with access to a CTG, ultrasound, and the ability to go for a caesarean section if needed. Usually a birth suite or maternity assessment unit would be suitable. We used to say that a woman had to be fasted and have a cannula in situ because of the risk of emergency caesarean section, but that risk is actually quite rare, and so this is no longer recommended. Next, we want to use ultrasound to confirm the fetal presentation and lie and ensure a recent formal ultrasound has been done to exclude contraindications to an ECV. And then we do a CTG both before and after the procedure. While the CTG is on, this is a good opportunity to explain the ECV procedure to the woman and ensure we have adequate consent.
Now, just to summarise the counselling required for an ECV, you should discuss why the procedure is being performed, that is, to reduce the risk of Caesar for breech, alternatives to an ECV, the overall success rate, that there's a small chance the fetus will spontaneously revert to breech, the risks, the procedure-related discomfort, side effects of any medications that may be administered, and management plans if the procedure is successful or unsuccessful. So that is a rupture of the membranes and induction, or a scheduled Caesar, or a second attempt at an ECV. We recommend using written information and a checklist to ensure all of these points have been covered.
Next, we want to administer tocolysis. Tocolysis is used to improve the success rate of ECV. It relaxes the uterus, which makes it easier and safer to try and turn the baby. Tocolysis is usually administered 20 to 30 minutes before the ECV. The most commonly used agents are terbutaline and salbutamol, both of which are beta mimetics. Beta agonists have been shown to reduce the number of caesareans and to increase the number of women with cephalic presentation in labour. Terbutaline is typically given as a subcut injection of 250 micrograms 15 to 30 minutes prior to the ECV. Salbutamol is administered by drawing up 250 micrograms in 25 mils of normal saline to make 10 micrograms per mil. Alternatively, you can draw up 250 micrograms in 10 mils of normal saline in 25 to make it 25 micrograms per mil. It's then administered in a slow IV 50 microgram bolus up to 250 micrograms total. Usually 100 microgram is enough until a maternal tachycardia is achieved. You do need to exclude a history of maternal cardiac disease, arrhythmia, or untreated thyrotoxicosis. Side effects include tachycardia, tremor, flushing, nausea, hypoglycemia, pulmonary edema, VF, SVT, and ventricular ectopics, although most people just tend to experience tachycardia, tremor, and flushing, which is a good sign that it's working. Other tocolytics have been shown to be less successful for ECV. GTN is inferior to terbutaline, and nifedipine does not increase the success of ECV or lower rates of Caesar.
So now it's time to get into the actual procedure. Ensure the woman has emptied her bladder and position her in a recumbent position with a wedge under her buttocks. Sometimes I find the wedges can be too big, so you can also use a rolled up towel. The ECV is then performed with either ultrasound gel, cornstarch, or talcum powder to reduce friction on the maternal abdomen. Firstly, you want to elevate the breech from the maternal pelvis and use gentle pressure to rotate the baby in a forward or backwards somersault, using pressure on the fetal head and the breech to affect rotation. Ultrasound should be used throughout to confirm the fetal heart rate as well as the fetal position. It's a little hard to teach the technique over a podcast, so if you are looking for any video guides, there are some really useful videos on UpToDate. The general consensus is to perform no more than 4 attempts over 10 minutes, although there is limited evidence to guide the number of attempts at ECV.
And it's important to know when to stop. Obviously, you should stop if there are any signs of fetal distress or significant maternal discomfort, but there are also clear indications for delivery after an ECV. Urgent delivery after ECV is indicated if there's a fetal bradycardia over 6 minutes, vaginal bleeding after the ECV, unexplained abdominal pain, or an abnormal CTG. Keep in mind that this is pretty rare, with less than a 1 in 200 chance of needing an emergency Caesar after an ECV.
Don't forget to check the maternal blood group. Women who are rhesus negative should have a Clyhow taken and be offered additional anti-D within 72 hours.
Now, don't be too disheartened if an ECV is unsuccessful. You can always try again on another day. There is also the option to use neuraxial anesthesia to increase the success of ECV. Routine use of this is not recommended, and I've certainly not seen anyone do an ECV under spinal yet, but it may be considered for repeat attempts or for those unable to tolerate the procedure. So how effective is an ECV?
We generally quote the success rate of ECV to be 40% in nullops and 60% in multis. 2 to 3% of babies will revert to breech after a successful ECV. They're so cheeky. Like, after all that hard work, they still disrespect you like that.
Some babies are so stubborn.
Yeah. After an unsuccessful ECV, 4% of babies will turn cephalic by term, which is why it's so important that if a woman chooses an elective cesarean for breech, that you should definitely confirm the fetal presentation with ultrasound on the day of the Caesar before starting the Caesar itself. Now remember, success rates are given as general statistics, and there are some features that may increase or decrease the chances of success.
Now listen up, because I've seen this as a written exam previously. Something like draw a table outlining features which may increase or decrease the success of ECV. Firstly, parity. Multiparous women are more likely to have a successful ECV than nulliparous women. Women who weigh less than 65 kilos are more likely to have a successful ECV than women with obesity. The type of breech is also important. Complete breech is more likely to be successful than frank breech. Polyhydramnios is more likely to be successful than oligo. A posterior placenta is more likely successful than an anterior placenta. If the fetal head is palpable versus not palpable, when the breech is not engaged, it's easier to perform an ECV than when the breech is engaged. A posterior fetal spine can also reduce the chances of success. Tocolysis can increase the chance of success.
There have been a few ancillary measures which have been proposed to try and increase the success rates of ECV. These include vibroacoustic stimulation, amnioinfusion, and analgesia. Vibroacoustic stimulation is basically where a device is placed on the maternal abdomen over the baby's head, and sound is emitted at a predetermined level for several seconds. The idea is that the sound and the vibrations stimulate the baby with a midline spine position to move to a spine lateral position, which makes it easier to move the baby in a forward or backwards roll. There has been one very small trial of less than 40 patients, which showed that vibroacoustic stimulation did reduce the rate of failed ECV. Amnioinfusion has also been suggested. Since polyhydramnios is associated with a higher likelihood of success with ECV, it makes sense that increasing the amniotic fluid volume may lead to higher success rates. Although unfortunately the data does not seem to support amnioinfusion. Analgesia may also improve the success of ECV. Nitrous oxide does not appear to improve ECV success rates, although remifentanil does seem to reduce pain, increase ECV success rates, but has no overall effect on Caesar rates. In general, most hospitals tend to not use any analgesia for this procedure.
Women should also be counselled that with appropriate precautions, ECV has a very low complication rate. We typically quote a 4.3% rate of minor complications, which include APH, ruptured membranes, and transient CTG abnormalities. Rare but serious risks include stillbirth at a rate of 1 in 5,000, abruption at a rate of 1 in 1,200, and emergency Caesar with a rate of less than 1 in 200. The overall complication rate is about 6.1%. Studies have not yet been sufficiently powered to estimate the frequency of uterine rupture, perinatal death, or long-term morbidity. It's also important to note that about 3% of babies revert to breech after a successful ECV. And if the ECV fails, 4% of babies will still turn head down anyway. Although a successful ECV reduces the chances of a Caesar, labour after ECV is associated with a slightly increased rate of Caesar, an instrumental birth, when compared with spontaneous cephalic presentation. So what does happen if the ECV fails? Are there any other options if a woman really wants a cephalic birth but she's had a failed ECV?
So alternatives include expectant management, postural manoeuvres, moxibustion, and acupuncture. Since about 4% of breech babies will turn cephalic after 37 weeks, women may choose to delay a caesarean until late pregnancy or early labour. Obviously, an emergency caesarean in labour for a breech baby is inherently more risky than a planned breech Caesar. This option may allow the most time for a baby to turn into the cephalic position. We often refer women to certain websites which neatly describe some postural manoeuvres to help rotate the baby into a cephalic position. These positions include pelvic elevation with a knee-chest position, supine head-down position with the pelvis supported by a wedge-shaped cushion, lateral position on the side opposite the fetal back. Unfortunately, there's insufficient data to recommend for or against the use of postural manoeuvres, although none of these manoeuvres are likely to be harmful, so women may still choose to give them a try. In contrast, home-based rebozo exercises actually appear to have a negative effect and may decrease the rate of cephalic presentation at term.
Moxibustion has also been suggested. Moxibustion refers to the burning of a Chinese herb close to the skin of the tip of the fifth toe. The procedure is performed for 20 to 60 minutes once or twice a day throughout the week for up to 2 weeks. A 2023 Cochrane review found that moxibustion plus usual care probably reduces rates of non-cephalic presentation at birth, but does not reduce the rate of caesarean section. They also mentioned that more evidence is required to determine the risk of side effects, which typically includes burns if you put it too close to your toe.
Okay, I'm going to have to look further into this and discuss it in the next Evidence with Anne episode, because I feel like I read the study that this moxibustion thing was based on, and it was subpar, to say the best. So we'll chat about that further.
Excellent.
Yes.
Can't wait.
Excellent.
Analysis with Anne.
Yeah. Alrighty, so for a quick summary on ECV. ECV is the manipulation of the fetus through the maternal abdomen to a cephalic presentation. It's offered from 36 weeks in nullops and 37 weeks in multis. Contraindications can be remembered by the March mnemonic: multiple pregnancy, abnormal CTG, ruptured membranes, contraindications to vaginal birth, and hemorrhage in the last 7 days. The success rate is 40% in nullops and 60% in multis. Factors that increase the chances of success include multiparity, weight under 65 kilos, complete breech presentation, polyhydramnios, a posterior placenta, palpable fetal head and a non-engaged breech, and the use of tocolysis. Factors that decrease the chances of successful ECV include nulliparity, obesity, frank breech presentation, oligohydramnios, an anterior placenta, fetal head not palpable, an engaged fetal breech, and a posterior fetal spine. The risks include a 4% risk of minor complications like ruptured membranes, an APH, or transient CTG abnormalities, a 1 in 200 chance of an emergency Caesar, a 1 in 5,000 chance of stillbirth, and a 1 in 1,200 chance of abruption. 2 to 3% of babies will revert to breech after a successful ECV, and after an unsuccessful ECV, 4% of babies will still turn cephalic anyway. Alternatives to ECV include expectant management, postural manoeuvres, moxibustion, and acupuncture.
So that concludes this week's episode on breech and ECV. Join us next time when we'll discuss vaginal breech delivery, other malpresentations, and the 10 breech trial. Keep an eye out for our summary slides on Instagram, and if you have any comments or feedback, please reach out to us on our website, theuterinesound.com, Facebook or Instagram at theuterinesound, or email us at theuterinesound@gmail.com.